Okay. Hey everybody. Why don't we get started? Uh, because the it's that time. It's that time to do CTisus quiz. It's our weekly quiz, and we're gonna get started. I got 11 cases, believe it or not. This patient has an acute abdomen, and the first thing you see is this really inflamed, thickened bowel loops. Right, very nicely shown there. A little bit of ascites, and you can see the loop really thickened. Here it is again. Now you could start thinking and saying, what could this be? Could it be Crohn's disease? I guess theoretically. Could it be ischemic bowel? That's a good possibility. Though the vessels look pretty good, at least what I see. Could it be some type of other process, including a drug reaction? Is the patient on chemotherapy? The answer is no. But look at the extent, how long the involvement is. The vessels are widely patent, so it's not going to be in all likelihood ischemia because the vessels look good. So what are we dealing with? Well, I mentioned to you chemotherapy, but I didn't mention drugs. One of the drugs that gives patients an acute abdomen that looks like ischemia is patients who are on ACE inhibitors. Within 24 hours or so, they get allergic reaction and severe angioedema, and that's what we're looking at on these images. Just a really, really nice example. An angioedema is a clinical description of inflammation, mediated edema, uh, but it occurs in the skin, but in the GI tract as well. The way you treat the patient is antihistamines, but you stop the medication. And so it's a great diagnosis because you don't want to do a exploratory laparotomy, right, for ischemia when it's simply medication. It's a diagnostic challenge. You can see the comments here. And it's a leading cause of drug-induced angioedema in the United States. Really, really good case, something to know about, because if you get in the situation of seeing the bowel and the patient said they were doing great till hours ago, never had a day of sickness in their life. Obviously, they're on ACE inhibitors, they have hypertension, but they went to their doctor yesterday and they were fine. And that's the classic thing. That's where AI is going to help. AI will find that diagnosis. Patient with GI bleed. When you look at these images, you see an enhancing lesion in the region of the patient's duodenum. Is it in the wall of the duodenum? Is it near the pancreas? There's no dilated common duct or pancreatic duct. You can see the lesion here very nicely. Vascular lesions in this region, I think of carcinoid, I think of a GIST tumor, and if it's pancreas, of course, then I'm going to be thinking about a neuroendocrine tumor, theoretically an enlarged node that's vascular, but this looks in the bowel wall. You can see it very nicely here on the volume rendering and on the MIP imaging, and that was a carcinoid tumor. Carcinoid tumor is vascular. GIST can be vascular as well. The GISTs are typically larger. When they get really large, they're not very vascular. A very nice example. We usually don't think about carcinoids as bleeding, but they can, particularly when they're in the duodenum. Shortness of breath. Look at the pericardium. Not only you would say maybe pericardial effusion, but look at the lobulations of the pericardium against the rest of the heart. This is not fluid, this is masses. And it's circumferential. It's really, really impressive. Look at the extent of that involvement. Now, if it was only focal, you could say, could it be a tumor? Could it be lymphoma? That's a good thought. It can be diffuse. Can it be pericarditis? The lobulations take it away from inflammation and fluid to solid. What are the solid tumors? Are there? Metastasis, a possibility. Lymphoma. The one that's most commonly by the right atrium is an angiosarcoma, but believe it or not, this was an angiosarcoma that involved the entire pericardium. Usually it's right-sided only near the right atrium, but just a terrific, terrific case. Mediastinal widening, there's a large mass. It's cystic when you measure it. Here it is again, displacing the tracheal bifurcation, pushing on things. It's not solid, so you're not thinking adenopathy. You're thinking fluid. What could it be? Duplication cyst, tracheal duplication cyst, bronchogenic cyst, a esophageal duplication cyst, something like that. That location, you can get metastasis, and you would make sure you're not missing a testicular tumor or something like that. But well defined, no invasion, compression. Got to be thinking about a bronchogenic cyst, most commonly tracheal bifurcation or right paratracheal space, but most typically, they're much smaller than that. This is one of the larger ones you're going to see. Another case, mass and tail of pancreas. Yes, you want to say pancreatic adenocarcinoma, that's a possibility, but there's no dilated duct. It's not very vascular. You can see it on some more images. It encases the vessel, so maybe it's still pancreatic adenocarcinoma, and this is arterial phase. Maybe it's not showing well. But when you get to venous, it didn't change a whole lot. So, what are you going to say here? Infiltrating tumor. I like lymphoma, but there are liver lesions too. I do like adenocarcinoma. That's a possibility. Well, this ended up being a neuroendocrine tumor. Okay? We always think about neuroendocrine tumors as hypervascular. They may not always be hypervascular, right? They can be hypovascular or isodense. And this is an example of one that's a little bit sort of in between hypodense and isodense, but it was a neuroendocrine tumor. Another case, dilated pancreatic duct enhancing lesion. Looks a little bit like the first case I showed you, but this lesion is not in the duodenum, it's in the pancreatic head. 1 centimeter vascular lesion. You can think about metastatic renal cell carcinoma, but the kidneys look good as we see them, and I'm not going to trick you that much. This is a classic appearance of a neuroendocrine tumor of the pancreas. Now, yes, there's a dilated pancreatic duct, and typically neuroendocrine tumors don't have dilated pancreatic ducts, but the answer is they can. Here it is nicely on the cinematic rendering, and this was a 1 centimeter or so neuroendocrine tumor. Back pain, large pancreatic mass, dystrophic calcification. It's kind of cystic with septations. It's displacing or compressing the stomach. Now you could think maybe it's coming off the stomach. Maybe it's a GIST tumor. Maybe it's a sarcoma. But those calcifications, really the stellate calcifications, the cystic nature of the lesion, which you can see in fact better on the venous phase, puts you into a cystic pancreatic mass. And yes, because of mass effect, there's compression and occlusion of the splenic vein, which explains the collaterals. But dystrophic calcification, cystic lesion large, thinking pancreas, you got to be thinking a serous cystadenoma. They get really large, commonly have calcifications. Just a wonderful example of a serous cystadenoma. Now we know serous cystadenomas, we just showed you one, have a range of appearances. Here's a lesion tail of the pancreas. It's cystic. There's calcification centrally. Yes, I would think about a mucinous cystic neoplasm or MCN. But, you know, with the septations and everything like this, now you get septations in MCNs and you can get calcifications, but this looks so cystic, you got to be thinking, yes, it could be an MCN. MCNs usually are in 40-ish-year-old women. Serous cystadenomas are in 60 to 70-year-old women. This is a good example of another serous cystadenoma. What a great case. Okay, patient had distal pancreatectomy. What's this mass? Is it a recurrent tumor? There's the stomach. The mass is low density, and it has some fat density within it. This is a classic thing. Often when you do a distal pancreatectomy or splenectomy, you can get inflammation in the omental fat. And this is the classic appearance of an omental infarct. And the reason it's important is you don't want to call this a recurrent tumor or an abscess. Omental infarcts typically will not bother you. They will often get smaller in time. I saw a case the other week where they were worried about recurrence in the left lower quadrant, and it was a large omental infarct. So something really good to know, and this was post-distal pancreatectomy. So we see them all the time, a really nice example. Okay, cystic lesion pancreatic head. We can again throw out the serous cystadenoma as a possibility. Mucinous cystic neoplasm, not the best location, but it's possible. Here you can see draping of the patient's GDA, which is draping is good for serous cystadenoma, but there's solid components, there's septations. What do you do with this? Well, if a patient was 19, you would say it's a SPEN tumor, solid papillary epithelial neoplasm, and that's a good thought. You would consider a serous cystadenoma. You couldn't rule out an MCN. It's not an IPMN, all these septations. And the patient was young, and this was a SPEN tumor. So again, you can see that we have certain specific features that we're trying to teach the computer, but It's not going to be perfect because there is overlap between cystic pancreatic tumors and SPENs, particularly when they're mainly cystic rather than cystic and solid, really can be challenging. So, one more case, GI bleed, multiple lesions in liver and spleen. Well, if you wanted to have a benign entity here, I would go with sarcoidosis, could be. But if not, I got to think about lymphoma, spleen and liver. If you tell me GI bleed, then I got to say lymphoma is a possibility, though unlikely or less likely. But I got to think of metastasis. And what mets go to spleen and liver and give GI bleed? That's a great question, but it's our old favorite, melanoma. And this is a case, here's a cinematic rendering of the liver and splenic lesions, and this was metastatic melanoma, which also gave the patient a GI bleed. So again, multiple liver and splenic lesions, theoretically could be abscesses if you're immunosuppressed, but they're too large for abscesses, usually candidiasis or aspergillosis. They're under 5 millimeters. You could think again of sarcoidosis, you can think of lymphoma, and then melanoma. Just a really, really nice example. And that's it. Those are all the cases. That's all I got. I hope you got them right. If you didn't get them right, I hope you learned something. And it was great sharing this 1 o'clock hour with you. And now, get back to work. Have a great day, everybody.